Everybody, welcome. I'm Avi Rose. I'm Interim Executive Director at Ashby Village, and thrilled that so many people are joining us today for this very important program on aging, ageism, and the future of elderhood, presented by Dr. Louise Aronson. We are honored that she is joining us, and we're thrilled that so many people are attending. Some of you are probably very familiar with Ashby Village already, but some of you may not be. Ashby Village is an organization and community in the East Bay that it's a network and community of people who are supporting each other to age in community with vibrancy and activity and a lot of forward movement. We have about 400 members. We have 300 volunteers. We have a community of supporters, and invite you to join us if you haven't done so already. We are very glad to be able to present these kinds of programs and this quality of program free of charge to all of you out there in Zoom land. If you would like to support our ability to continue to do so, we invite you to donate to Ashby Village, and Jessica will put a link in the chat to facilitate your support. Without further ado, I'd like to turn this over to Roberta Pressman, who is the leader of our Healthier Aging team and organizer of this event, and we'll take it from here. So thank you very much. Here's Roberta.
Good afternoon to our Ashby community, and welcome to our many guests from across the country. It's so great to see so many of you here today. And a very special welcome to you, Dr. Aronson. We've been eagerly awaiting this event, and we're so honored to have you with us today. We especially appreciate that you've made yourself available all the way from England, despite the difficulties that unexpectedly brought you there. But before we hear you speak today, we want to take just a little time to celebrate you for all you've done to promote a better life for all of us elders. We want to celebrate you for your compassion and care that you've demonstrated as a working geriatrician. You've been an outstanding example of the practice of medicine at its very best. We want to celebrate you for your writings, which have given us the words to the music of our experience as elders. In this youth-driven culture, you've had the boldness to take ageism out of the closet, especially out of our healthcare system's closet, and brought it front and center into our consciousness. In an age when increased attention is being paid to diversity, equity, and equality for marginalized groups, you've noted and called out how ageism, which negatively affects the healthcare of a growing proportion of our population, is not referenced much, if at all, as an ism worthy to be attended to. You've shown us through your beautifully crafted case examples how the medicalization of the normal aging process and the negative stereotyping of elders has made the ability to grow old well so very challenging. But you've also happily reminded us that despite the challenges, there are many often unmentioned joys of being an elder. And lastly, we celebrate you for your book, Elderhood, a true gift, a refreshing, nuanced, and comprehensive examination of what is lacking and what reforms are needed, both in medicine and our society at large, in order for all of us to experience the best possible elderhood, a stage that many will find ourselves living in for a third of our lives or more. It's truly must reading for all of us approaching or already living in elderhood. For all of this, we thank you and we celebrate you. For those of you who don't know much about Dr. Aronson, she's a leading geriatrician, writer, educator, and professor of medicine at the University of California at San Francisco Medical Center, and the author of the New York Times bestseller and Pulitzer Prize finalist, Elderhood, Redefining Aging, Transforming Medicine, and Reimagining Life. She attended college at Brown University with absolutely no intention of becoming a doctor. In fact, she states that she studiously avoided all math and science courses, majoring instead in history and adding courses in anthropology, psychology, and literature. She eventually did choose to study medicine at Harvard Medical School, where she earned her MD and later earned a Master of Fine Arts in Fiction Writing at Warren Wilson College. Dr. Aronson returned to San Francisco, her hometown, for her medical residency and has spent most of her professional life at UCSF Medical Center, where she's received numerous awards for her teaching, educational research, and writing. Just some of these awards are the Gold Professorship in Humanism in Medicine, the California Home Care Physician of the Year Award, and the American Geriatric Society Clinician Teacher of the Year Award. At UCSF, she served as director of numerous projects, including the Pathways to Discovery program, the Optimizing Aging project, and as chief of geriatric education. Her writings have appeared in the New York Times, the Atlantic, the Washington Post, the Journal of the American Medical Association, and the prestigious New England Journal of Medicine. She has been featured on the Today Show, CBS This Morning, and National Public Radio. And this is but a very small summary of how much our speaker has accomplished. Do read her book, which incidentally is now in paperback, to learn about all the other big and small ways she has contributed and is still contributing to making the lives of us elders safer and more satisfying. Dr. Aronson, welcome.
Thank you for this fabulous introduction. It was one of the best I think I've ever had, so I appreciate it. And I'm also, we all have Roberta to thank for me being here because the pandemic led to some chaos and she was persistent. So I thank her for that. So I'm going to get us started here by sharing my screen. And we are indeed going to talk about aging, ageism, and the future of elderhood. When we were discussing what to talk about, it seemed that ageism and some of what I discussed in the book, and yet taking it another step would be good. I'd also love to talk about healthy aging, and I'll slip a few things in, but that is another topic altogether. Except for the fact that unless you're aware of ageism and able to cope with it, it's hard to have as healthy an aging as all of us would like for ourselves and the people we love. So I'm going to get us started. You know, there are these people who say, you know, age is in your mind, or 70's the new 50, or, you know, age only matters if you're a cheese, etc. And we all know, I mean, I think anybody over what, you know, 40, 45 knows that's not true. And then came COVID. And this is a graph from early on, but it didn't change much. And it really showed a couple of things. One is that, you know, age doesn't happen, boom, overnight, which somehow I think even as a young geriatrician, I imagine might be the case. And it sort of becomes more so with time. So you see here that the rate of death from COVID started going up when people were in their late 40s, and then it steadily marches up and was hardest of all in people in their late 80s. Except that's actually not the whole story. Yes, age matters, but it was only part of what has happened in this country these last 2 years. So we see here some data from in 2020, actually, looking at racial and ethnic disparities in COVID-19 deaths. And these are among people aged 75 to 84. So the second highest group. And it turned out the rate difference, the risk difference, was nearly 900 if you were Black in this country, and over 500 if you were Latinx, and over 200 if you were Native American, and about 150 if you were Asian or Pacific Islander. So yes, there's age, but the fact that race and ethnicity made such a difference in the risk of age suggests that maybe age isn't the whole picture either. Now, when it came to race, this was a study that looked only at Medicare beneficiaries, so the vast majority of them over age 65 and over, and found that the reasons they were more likely to die was that they were being treated in less good hospitals, which tended to be in the neighborhoods where they lived, and that in fact, if they went to those hospitals with a ruptured appendix or a pneumonia or a heart attack, they were also more likely to die. It was about the quality of care they were able to access, not necessarily something that had to do with who they were or the color of their skin or the culture from which they came. Similarly, people often think, oh, well, people died in nursing homes because those are the oldest and the frailest of the old. Now, when it said about 8% of people who live in US long-term care facilities died of COVID-19, that was because people died in assisted living also, 1 in 12. But in fact, for nursing homes, it was about 1 in 10. 1 in 10 people. And some young people imagine that, oh, probably that many die every year. No, no, no. These were people who died partly because of COVID and partly, hugely partially, because of our response to COVID. Because policies and priorities matter in who dies. What we saw in nursing homes was that they did not get PPE when hospitals and clinics did. 7 months into pandemic, 20% of facilities, so 1 in 5, did not have PPE yet. 7 months in, they were not prioritized. They weren't thought about. They weren't considered healthcare, even though their regulatory bodies are healthcare bodies. Similarly, testing, very hard to get testing. This was year 2 of the pandemic, still having trouble getting testing. And then even vaccination, the one thing that actually sort of went right, was slow. Why was it slow? Because the people making the decisions didn't actually know how nursing homes worked. They were in charge of them, but they didn't know anything about them. So contracts were made with CVS and Walgreens. What they didn't realize is that all nursing homes have contracts with pharmacies to begin with. That's how they get medicines for the people who live there. And so CVS and Walgreens had no idea how to write a consent form for a person with dementia or a staff person with low English proficiency or a person who doesn't see very well anymore. And so there were delays and delays and delays, nearly a couple months worth. And how many people died in that time? Many, many tens of thousands. Now, it's not that age doesn't come with risks. This is somewhat depressing curve. Anyway, you see that there is some risk when we're born, and then our risk of death is pretty low. This is old data from 2010. It's hard to find a newer picture, but basically, throughout recent history, it's been this way. And again, sort of just like COVID, the risk for death starts going up around age 45. It's that when you're entering middle age, and then you're an older adult, and then you're old, and the risk goes up and up and up. So I'm not arguing that there aren't some risks with age in terms of your health and in terms of other things. Now, I should say, and Roberta mentioned this, I talk a lot about health and healthcare here. That's partly because it's a bigger part of our lives as we get old. It's partly because I know a lot about it. And it's partly because it serves as a very good window into how society in all other sectors handles things. Yes, I'm going to show you about health, but look at how we handle our parks or educational programs or city planning or anything else, and you will find very similar changes and approaches to them. But old age also offers opportunities. If we think of who is kind of running the country to some degree, these are people by and large, the youngin is in his 70s and the others are all in their 80s. Now they all have the same color skin, and that's not coincidental. So for some people, it offers opportunities. And indeed, there is an almost 40-year span between the people, the Native Americans in the Dakotas, who have the shortest lifespan in America, and the East Asian immigrants in Massachusetts who have the longest. So how you live, who you are, where you are, it all matters. Now, you might have thought I'd already begun, but actually that was just the preamble. Today, I'm going to do this a little bit like a 3-act play, playing off Elderhood a bit for those of you who've read it. In that book, I talk about childhood as Act 1, adulthood as Act 2, and elderhood as Act 3 in a 3-act play. We're going to do something a little variation on a theme here, discuss where we are now. And again, I'm going to pull in COVID and healthcare, but that shows you the ways, the insidious, the nefarious, the surprising, the unsurprising ways that we disadvantage older adults, consider how we, and by that I mean all of us, might be contributing to the problems, and then identify some better ways forward. For those of you who want a more academic-y thing, I'm going to talk about what we learned from COVID about aging. I'm going to talk about how our general approach to aging may make the challenges of growing old worse. And then we'll talk about steps for improving elderhood for ourselves and for future generations. But first, it's important to define ageism. And maybe I don't have to do that for this group, but it always seems important to note that it was only coined in 1975, long after the other isms, but still at the height of sort of civil rights awareness, by Bob Butler, who was a psychiatrist and the founder of the National Institutes on Aging. He said it's a process of systematic stereotyping or discrimination against people because they are old, just as racism and sexism accomplish with skin color and gender. I actually think he got it a little wrong. I think it's a process of systematic stereotyping and discrimination of people because of their age. If we want to make it truly analogous, it has to be any age. So I don't know about you, but I'm already guilty of this, where I see some kid crossing the street looking at a device and not paying any attention, and there's something in the ears so that the kid can't hear. And I think things that are probably ageist. Although I also think that's just foolish behavior, and no matter what your age, but you know, we all do these things. And I think to the extent that we can be better about it, we create a world that's better and less ageist. Dr. Butler also said that in terms of ageism against the old, that ageism allows younger generations to see older people as different than themselves. This comes into play as we see our COVID response, as does the second part. Thus, they subtly cease to identify with their elders as human beings, so people of lesser value. This was a Time magazine headline, "The Road to Recovery, How Targeted Lockdowns for Seniors Can Help the US Reopen," because of course seniors aren't part of the US. And then there's also the irony that the initials for our country spell us. So there's us and there's those seniors who are kind of dragging us all down, right? You have this woman who's holding a child who says, "You can call me a grandma killer." Can you imagine somebody putting a tweet out there, "You can call me a baby killer," or "You can call me a such thing," or I mean, I suppose actually maybe they do, but I don't follow people like that. But still, there she is, what my colleague would call a grandma in training, right? If she's a mother, with any luck, she'll become a grandmother. But it is so inconceivable to young people that this has anything to do with them, that the empathy is just gone. An ethicist, a famous ethicist, Peter Singer, who won a big award recently and had a profile in the New Yorker that was interesting, asked whether age discrimination is acceptable. I was at first outraged at the question because I don't think in this era we would ask in an international publication whether gender or race discrimination was acceptable. But his answer actually was acceptable, if you want to look that up. And then there was this from our government. Literally, people who died in nursing homes, their lives were not counted. The federal government gave a pass for anyone who died from COVID or from something else or from COVID in February, March, and April. So your life literally wasn't counted by your government. It's really hard to imagine that happening to another group of people. This was a terrific article in the New York Magazine, New York Intelligencer section. And she sort of goes through the history of why we shouldn't have been surprised what happened, but she also points out how this really was a matter of policy and priorities, all those early deaths in 2020. So the governors, and particularly here, those of New York and New Jersey, calculated the risks. And when there weren't enough hospital beds, so here was a problem with older adults. Could they get better? Yeah, it seemed like they could. But darn it, they did it more slowly than other people. And so older adults who came in from home were sent to nursing homes in order to free up hospital beds for other people. This was a point where people of all ages were getting COVID, and sometimes older people weren't getting treated quite the same way. But so what did they do? They took those people with COVID who weren't getting well fast enough, and they sent them to nursing homes that at that time had no PPE, had no units for people who were sick. And so a lot of those people who were sick with COVID. So a lot of those people died who might have been helped had they stayed in the hospital. Plus, they gave COVID to the workers who gave it to their communities, mostly brown and Black communities that we then saw die, and low income communities. Those people died in higher numbers too. And the staff went from place to place without PPE and without the ability to test. So they took COVID to the other residents. So basically, the governors sentenced a whole category of people to death. There are lawsuits on that now. The interesting thing that we've learned more recently, this is an article from late in 2021, that there was a striking racial divide in how COVID hit nursing homes, that nursing homes with a significant number of Black and Latino residents were twice as likely to hit by COVID. Now that actually flipped in the latest surge, where ones that were more white were more likely to be hit. And that just shows how policies and priorities and access to preventive and treatment measures make such a huge difference in who gets sick. This was known to be the most vulnerable population, right? We heard from China, we heard from Spain, we heard from Italy. In every country, and these are countries who handle aging very differently, old people were disproportionately dying. So you might think, and you might well imagine, that if it was another segment of the population, we would have put resources there preferentially instead of secondarily. Not only that, but the federal government, the Centers for Medicaid and Medicare Services, which oversees nursing homes, waived the training requirements and suspended inspections, right? So the people who usually inspect were kept safe, right? So those tend to be higher level people, nurses. They got to stay home and work from home. But the low wage staff had to go in and risk their lives, which many of lives were lost. And also there was no oversight. So there were people with no training and they didn't know how to cope with a pandemic. They're not healthcare workers in that way. And then no oversight. So as this attorney writes, waivers designed to cut red tape to swiftly protect residents would be one thing. But these moves instead leave residents largely at the largely unsupervised mercy of overwhelmed institutions. I'm going on and on about nursing homes, not because most older people live there. A tiny minority do live there. Many of us will pass through one at some point in our lives, perhaps at the end of our lives, unless things change. And it's also the only area for older adults where we have good data. Now, for other populations, we have data on kids in schools. We have data for people in adulthood and workplaces, although there are also some older adults in workplaces, of course. But this is really the only place we have access to data on older people. Now, in terms of disease presentations, there is something called atypical presentations. These were first talked about for women in the middle of the last century, when, as researchers were studying heart attacks, they found that they presented differently in women. So they were called atypical. Now, if you happen to be female, this is a typical presentation. But if you're a male, it would be atypical. But still, to this day, we call them atypical. And many of the presentations of older adults are atypical for their disease if you define the disease, how it presents in adults. Now, we saw from China and Italy that older adults had atypical presentations. What does that mean? That meant a lot of people didn't have shortness of breath. A lot of people didn't have fever. We know as we age, we're less likely to have fever with an infection. A lot more people had confusion. A lot more people had falls. A lot more people lost their appetite or got intestinal upset. All these things were known by the time COVID hit the Bay Area, at least that we knew it hit the Bay Area in March. I had read articles from China, articles from Italy. But what happened here? What happened at our state level? What happened at the federal level? We heard about algorithms for care and workflows for adults and kids. In fact, we had our kid one first, even though, and I'm not arguing for the death of children or wishing that more children had died or would have died or anything like that, but there were literally thousands of kid deaths and hundreds, many, many hundreds of thousands of elder deaths. But we didn't ever have official workflows. And this is just, I initially made a little, a few articles in the bottom right corner. There are so many articles on this proving it. So when the health system says it practices evidence-based medicine, it is lying. Now, in terms of research, a a lot of the trials, we're hearing a lot lately about vaccination for the under fives, right? Because there still isn't one. And then the vaccine for the 5 to 11s is questionable. Why were they delayed? Well, because the trials weren't going the way they wanted them to. Oh, but there were trials. The one age group on whom there weren't trials, there were a very small number of people into their 70s community dwelling in the vaccine trials. There were not older people in health in facilities. There were not older people who were in their 80s, 90s, or 100. So the only group on who was given vaccines without any proof that they worked or didn't have fatal side effects was older people. Now, it turned out that worked out really well, but let me assure you that was dumb luck. That was not good science or health equity. Public information. If you looked at the CDC website for most of this pandemic, you would get what I call an adultist view of the world. So you would see the things you needed to know about the pandemic, symptoms, testing, vaccines, etc. And you knew it was for adults because there was this pullout section for children and teens, and that was super helpful because it had 9 subsections, things for parents, stop the spread, all these things particular to kids because kids aren't just short adults. They're different. We all know that. But the interesting thing is if you're going to talk about age, if you're going to divide people into age groups, you think you might include the group at highest risk, and yet you cannot find them on the list. You can't. It turns out if you look really hard and you click all those pluses, you do get them. You find them under people at increased risk. But they're divided not into age, not into all the differences in how our hearts and lungs and brains and kidneys and everything functions as we age, but instead people with certain medical conditions. Well, you could be 25 and have diabetes. And then other people who need extra precautions. That was sort of to cover like everybody with any disability. So lumping people into unfair categories. Now, as the pandemic progressed, although not until late in 2021, they did a little better and they started pulling out all these people with different conditions. But they still didn't highlight older people, except to the extent of like caregivers of people with dementia, adult day service centers. So at this point, by the time they put up this new menu, 80% of deaths were in older adults, and they still don't have a pull down menu equal to that for kids, where a tiny proportion of deaths were in kids. Now, we're supposed to be in the harm reduction era. Pre-pandemic, we knew that 43% of older people feel lonely on a regular basis, and that when you feel lonely, your risk of death goes up. It's worse than having diabetes or smoking your whole life. And yet, we also knew that people who have impairments in hearing or thinking, which might be what they have at baseline, or it might be because when you get really sick and you're older, you are liable to get confused, especially if they give you certain medicines, need their caregivers. But most hospitals allowed the parents of children, allowed the partners of people giving birth, and allowed people if you were dying. Well, the interesting thing here was that if you had dementia or you had bad hearing loss, or if you basically had a caregiver who did a lot of the history giving for you, you weren't dying until you probably went to the hospital and then you got an inaccurate history and you couldn't communicate for yourself or fight for yourself, and there was no one there to fight for you, and then you were dying, and then they might let your caregiver in at the very end. And this went on in most hospitals across the country, some pushback, but it turned out to be more variable. So the caregivers of people with dementia, and I have fought this for a friend in Napa, it would be on the books, but you'd really have to fight, and it would be at the discretion of the supervisor that day. So truly a different standard, a lower standard, a worse standard, an unsafe standard for older adults, especially those at greatest need. This was a study that just came out actually last week, showing that policies that restrict visits to the emergency room contribute to poor quality care of older patients and contribute to structural racism. So not only was there structural ageism, which they don't say because, well, that's a different conversation, but it turned out it probably contributes to structural racism because if you're Latino, the prevalence of dementia is higher, and if you're Black, the incidence is higher, which just means you're more likely to have it. But who's more likely to get to be the exception? Well, it's the wealthy white person who can articulate for their, here's why I need to get into my mother, blah, 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 or maybe you pull strings or whatever else. And we know Latino and Black families are more likely to providing hands-on care, so they're going to know more about how to care for their elder. And so this was not only structural ageism, but structural racism to boot. You keep seeing how these things come together. And then I was driving back from clinic maybe 2 weeks ago now, and Marketplace came on. The NPR listeners will maybe recognize this. So it was something to talk about how much was learned from the AIDS pandemic when it came to COVID, and a lot was. But here's a famous epidemiologist at Yale talking about how when the AIDS pandemic started, it was thought of as a disease of disposable people, gay men, Haitians, hemophiliacs, people no one wanted to pay attention to. And then they go on to talk about how in the COVID pandemic, Black and Latino communities suffered the highest case and death rates. There's an entire program about the people who are considered disposable, the people no one wants to pay attention to, the people with the highest death rates. Not one time are older people mentioned. Now, that isn't to say the death rates for Blacks and Latinos aren't higher. I've shown you that several times already, 3, I believe. But if you look at the people at very highest risk, and also it's worth mentioning that you can actually be Black and old simultaneously, but the people at very highest risk are the people 85 and up. So an entire program, no mention of old people. Similarly, Bob Wachter, some of you may be listening to him or following him or hearing him on the news. He's admittedly my boss, but he was talking last week about all the good news, before BA2 arrives for us. So saying now COVID's mortality is low, really, truly, he says, as low as the flu, maybe even a bit lower. Like that's really good news, and it kind of is. Flu on the left, COVID on the right. COVID is worse. But look at the people for whom flu is kind of bad news, the 65 and up. So it's only kind of good news that it's like the flu if you're under 65. If you're over 65, it's better than COVID, but it's not exactly good news. It's a major cause of death in older people every single year. And he's in his 60s. So this brings up one of my key points, which is we tend to think of old as something we're not. It's always kind of older than we are. And that is really dangerous because in a couple years, he'll be 65 and then he'll be part of this group that I don't think he's giving full fairness to. This is Ontario Human Rights Commission's statements on ageism, which are pretty terrific if you haven't looked at them. From a human rights perspective, they say there is a lack of sense of moral opprobrium linked to age discrimination, which in comparable circumstances would generate outrage if the ground of discrimination were, say, race, sex, or disability. Now, I don't believe they're arguing that we do a good job of any of these things, but we at least mention them. So when you look at the pandemic response, there were 9 key elements. Older people were prioritized for 1. And you see here that all US COVID deaths are in gray and deaths among residents of nursing homes in red. And once people got vaccinated, they plummeted. So actually, when they received the best care, the care many people were receiving early on, had there been PPE and training, and supervision and testing, there would not have been the slaughter there was. So doing the right thing does make a difference. Age matters, but age isn't everything. So now we're going to move to Act 2, wherein we consider how the way we talk about and approach old age might contribute to the challenges of growing older, even when we mean well. So there are many ways of talking about old age. In some circles, people think, healthy aging or so-called successful aging, a term coined in the 70s. I don't like successful aging because it means every single one of us will be failures if we live into old age, because you can only be successful for so long and then actually you're old and then inevitably you die. So is it great to eat kale and blueberries? Absolutely fantastic. Very good for you. If a car hits you, not so helpful, but still a really good idea to eat well. But does it mean you're not going to grow old? It does not. And then there's the exceptional elder story, right? Oh, this person, this 89-year-old clown climbed Mount Everest. This This guy has perfect abs. This woman can do the splits. When we tell the exceptional story, it makes all of us who are human and mortal think, well, that's an exception. That's not what we could all do. It doesn't tell the story of what we all might do better. And that is where I think healthy aging is most exciting. That is where we can transform lives by combating inner ageism in people and also giving people education about all the ways you can be healthier as you age, regardless of your age and functional status. Not that you can be 35 again or even 55 again, but you can be better and happier and healthier at whatever age and function you have now. And that's actually an exciting program we're working on at UCSF today, where the exception, hopefully, maybe not this exceptional, but the good aging, the healthier aging is something available to many more people. And then there's the evil silver tsunami, because there's no upside to a tsunami. So we live in this culture that's confused, right? That no one wants to die, but then no one wants to grow old. And you actually kind of have to do one or the other. And then actually, once you grow old, you still have to die. So you can die early or you can die late. It also pits generations against each other, as if the old people, as you age, you really spend all your time thinking about how to destroy the lives of children. And it also makes old people look all the same, when in fact, we are more diverse as we age, not less. And I mentioned this at the beginning, these books that sort of lie to you. Old age is always, it should say 15 years older than I am. Age doesn't matter unless you're a cheese. And then these things that perpetuate what Butler called the stereotypes, how not to become a crotchety old man, how not to become a little old lady. Well, honestly, if you live long enough, you're going to become shorter. It's what happens, and that's a whole other conversation. But if you're a happy, healthy little old lady, I'm game for that. This is from Boston's anti-ageism, so not anti-aging, but anti-ageism campaign. And my concern is that it's ageist. So here's this stunning woman, age 86, looking better than I did at 16 or 26. And she says she's a lot of things, but she's not over the hill. I actually think this reinforces the stereotype. It says that what over the hill means is that you're sort of out of touch and out of date. Whereas if we're literal about over the hill, then it means you're past the midpoint in your life. And it's probably because we think so little of people past the midpoint that we have trouble with old age. Employment discrimination based on age in this country kicks in at age 40, because that's when employment discrimination begins, particularly against females. So we are over the hill, depending on how long we live, 35, 40, 45, 50, maybe even 55 if you're lucky. Wouldn't it be great if instead of saying she's not over the hill, we said, hey, over the hill looks lots of ways. I've been over the hill for 35 years. So what of it? And similarly, this is another caption from them, a man saying, I'm many things, but I'm not frail. Well, honestly, if I look at him, I see the bend, I see a bunch of stuff, and he's going to be frail in a matter of years, maybe sooner if he gets unlucky and has an accident or gets sick. But now he's sort of creating a world in which the people who have more value aren't frail. And one of the problems with aging is that just as young people push away old age, older people who are healthier tend to push away the less healthy older people. And that perpetuates the cycle of devaluing people based on what they can or can't do. That is one of the fundamental problems with ageism. We need to think about our inherent value as human beings. So this is UCSF's diversity poster. So we apparently welcome people of all races, religions, countries of origin, sexual orientations, genders, ethnicities, and abilities. But we don't want people of all ages. I like to joke that at least they're honest. But I think they literally think so little about age and ageism that it is not included here. Similarly, we had a big climate survey and they didn't include ageism. And when I sent a very polite note saying you've asked about every other ism, but not this one, they said, oh, but we don't need to ask about that. We have demographic data. And I said, but you have demographic data on race, religion, country of origin, sexual orientation, gender, identity, ethnicity, and ability. but you still ask about discrimination about all those things. And they could, it was 3 emails before they could hear it. In medical education, we spend a few days to a couple of weeks on old age, even though older adults who are about, on average 17% of the population are nearly 30% of outpatient visits and 35 to 40% of inpatient visits. So days to weeks, few months on kids, and years on adults. It's a very adultist system. In public health, these are vaccine schedules. On the left is kids, on the right is adults. You'll see there are lots of different subsections for kids because we decide on these based on your immune system, your social behaviors, and your biology. Now for adults, there are actually 3 subsections for people ages 19 to 64. 65 plus, a period of time that lasts now 45 or more years, in total. More and more people are living into their higher 100s. So there's a single category. We have known for decades, actually even centuries, that the immune system changes dramatically with old age. That's why I hope all of you have gotten the 4-fold stronger, the high dose flu shot. Why? Because your immune system doesn't work as well. So you need 4 times more of the flu shot. So on the one hand, they do that. And on the other hand, they don't think about the difference between 65, 85, and 105, for example, even after the pandemic. And in medical research, there were rules to include women and minorities beginning in the 80s, rules to include kids beginning in the 90s, rules to include older adults in 2019. This despite the fact that when they looked at studies that only included men of a certain, white men of certain ages, they found that harm was done to women, to minorities, to children, and to older people. But literally decades later, decades before they mandated inclusion of older adults in studies that influenced them. Now, older adults get left out based on age alone, but they also get left out based on having certain diseases, some of which are more common as we grow older, though happen to adults, and some of them happen only in old age. So what happens if you study the healthiest older people and then apply it to the people who have diseases? Well, the people with diseases don't do as well. The risks are higher and the benefits are lower. So unless you study the people you're going to apply the results to, you do harm. And that's what happens a lot. The medical system does harm to people and then it blames old age for having treated them unfairly to begin with. It notes that they're different and then blames them for the difference that it didn't take into account. In clinical care, this was a great article by Judy Graham, who writes for Kaiser Health News, terrific stuff about aging. And quoting a UCSF professor, actually, who's in her 80s, but still teaching and teaching on Zoom, can Zoom just fine to teach. They treat me like I'm old and stupid. That was going to the emergency room and just being, dismissed and not given autonomy or choices. And then being sent out, late at night, with nothing warm, just a crazy problem that happened. And no help, I don't know, read the article. It's so upsetting. I'm losing my ability to speak. Anyway, and then there's our healthcare system as a whole. So I'm picking on the home team yet again, but at UCSF, we have a fancy newish children's hospital. We are about to build a new adult hospital, great big hospitals, specialists and subspecialists in both of them. What do we have for the age group that disproportionately requires medical care? Kind of akin to the way kids require education and adults require, workplace help or, do military action. That there are things that we do only at certain stages of life. Healthcare happens to be the one for older people, and yet they're blamed for that. But you don't hear people saying like, my God, kids take 96% of the education budget. It's so disproportionate. It's insane. You don't ever hear that. What do we get for older adults? We get something called an age-friendly health system. And if I were actually to show this proportionally, you wouldn't even know it was on my screen. Systems get labeled as age-friendly if some part of the system is thinking about asking an older person what matters most to them to decide on the risks and benefits of treatments. If they think about medications that might be doing harm as well as good, since the vast majority of adverse drug reactions happen in older people. If you think about how well they're thinking, we saw that with COVID, confusion was quite common. 1 in 3 people presented with confusion. And then whether people can walk or not, because too often we begin losing muscle mass at age 35. So if you're in bed for a while and you're older, your muscles will take longer to recover. Can you recover fully? Yes. But is the health system ageist? Yes, because they'll say, oh, he's walking so well with a walker. Do they ask, did he have a walker when he came in? Do they realize that with more treatment and more work on muscles, he won't need the walker in many cases? No, they don't realize that because they're not taught in physical therapy schools or nursing schools or social work schools or occupational therapy schools much about older adults either. So on that depressing note, we're going to end and shift to things that we can all do to improve elderhood now and for future generations. In addition to, I just have to say, all the stuff that I talked about, feel free to make noise about it and say this isn't right and it isn't fair and we're not going to take it. So the World Health Organization actually has a nice definition of healthy aging, which is being able to do the things we value for as long as possible. And they've identified 4 things, and I think this is as good a framework as any. A change in the way we think about aging and older people. So that's a lot of what I'm trying to do today. But creation of age-friendly environments all over the place, and not ones that are age-friendly, like age-friendly health system, like I just showed you, which is like a tiny fraction of what adults and kids get. But truly age-friendly cities, communities, states, countries. Alignment of health systems to the needs of older people. I've showed you how it is very much not that. And then development of systems for long-term care. Even prior to COVID, long-term care was not something most of us wanted to end up in. I mean, sure, there are the lovely assisted living places. Anybody saw the article in the Times, I think it was December before Christmas, about these like places in New York that are like being at a 5-star hotel. Okay, that's great if you can afford it. But that isn't what most people are going to get. And it's the rare person who really looks forward to moving into a nursing home, although it will happen to a majority of women at some point and a huge proportion of men. People often go in and come out and go in and come out, etc. Now, this is going to scare some people, so don't worry about it. It's the principles of biomedical ethics. I just want to show that these align really well with what the World Health Organization is doing. And I wanted to point out a few things. Autonomy. One of the things that autonomy says is you have a right to make decisions, but it also is that humans are a means unto themselves and not a means to an end. When you're thinking about your own internalized ageism, people will say, well, I'm no good anymore. I have patients say this to me. There's not much more I can do. There's actually lots of things they can do, but what they're seeing is a sort of adultist view of what they can do. So maybe they're not going to work a 50-hour week anymore, and maybe they're not going to go for a 5-mile run, but they're discounting all the things they do and all the other things they could do. And also they're counting their value based on what they do and not who they are. So think about this. Beneficence is an obligation to contribute to persons' welfare. We saw how the medical system and the public health systems and the state governments and the federal government did not practice beneficence in terms of older adults in the pandemic. And then non-maleficence is the obligation not to inflict harm, and indeed the policies inflicted harm. And then justice for healthcare. This is the distribution of health and healthcare in a fair and equitable way. And again, we've seen that isn't the case. So, everybody has worth. Long-term care could reflect that better. Beneficence, do good, change in how we think about aging and older people. Non-maleficence, I mean, if we had age-friendly environments, we'd stop harming people. Are you going to go, if you've got a really sore knee, are you going to go to a place that requires you climb up 1,000,000 steps and there's no rail? Are you going to go to a restaurant that's supposed to have the best food and food is your thing, but you won't hear anybody you're talking to? And then justice, alignment of health systems to the needs of older people. So there is an ethical and decades established ethical imperative for this. It's not just the World Health coming up with it out of nowhere. So I'm actually going to go through these backwards to end kind of where we began in thinking differently. So development of systems for long-term care. Really interesting in the pandemic, but I think this quote from James Baldwin, I've talked a lot about intersectionality today, the way, you could be female and old, and Black all at the same time, for example. But you look at this picture of a nursing home, which is what all of us hope not to live into. Um, and Baldwin says, people who treat other people as less than human must not be surprised when the bread they have cast on the waters comes floating back to them, poisoned. We hear at continuing care communities all the time that if somebody has a stroke or has a fall and isn't themselves anymore, the people in the higher functioning units want that person gone. So instead of having empathy, thinking there, but for the grace of God or whatever you believe in, go I, they think, I don't want to look at that because that scares me. We have to get better at looking at what scares us in order to create a decent world for the people living that life so that when we get there, it will be decent as well. One of the great things that was discovered in COVID was that non-traditional nursing homes, so you may have heard of the Greenhouse Project, had almost no COVID cases. And these are places where the staff retention is higher and pay is better, and when people can eat dinner not at 4:30, but actually when they're hungry. And they have activity hubs, and so they're in smaller groups, which are kind of like neighborhoods or communities. And people can pick and move around. So lots of good things. And there's been studies of this showing, why they had fewer COVID-19 cases and deaths. The VA system has adopted this going forward. So its new facilities will be built in this model where people are happier, both the workers and the people who live there. The state of California is looking at it. The state looks at things slowly. And then we need to talk, and I've alluded to this, about sex, gender, and nursing homes. On the left, the darker color is females and the lighter color blue is males. So you can see that the people living in nursing homes are majority female, and that's particularly true in the older age groups. 90% of people who work in such places are also female. So this is why the pay is less than people get paid working for Amazon, working at the grocery store, working somewhere else. So imagine if you're just moving groceries and putting them into the machine, you get paid more than if you're taking care of someone's loved one. Yeah, there's no more to say about that. We care so little that we do not pay people to do work with what ostensibly is what is most precious to us as humans, the people we love. Long-term care, lots of things here also saying, just showing that the number of males per females declines as people get older. There are just way more females. Female workers are also had to take leave more to deal with kids at home or elders at home. And so they will have less retirement income. Female workers also tend to universally make less on the dollar than males. So they live longer. They have more hits to the retirement income because they have to take more time out for caregiving, and they're paid less to begin with. So what happens is increasing poverty and ending up in nursing homes. And then this from the New York Times a couple years ago, why aren't more women working? This was specifically speaking to middle-aged women. It was because they were caring for patients. And this was particularly people in the middle income groups who could afford to stop working and care for their parents. So middle class, upper middle class people, if you're truly impoverished, you keep working and your parent goes into one of those nursing homes where people were much more likely to die. Number two, what is needed for healthy aging? The alignment of health systems. Actually, that's number three. Number two, alignment of health systems to the needs of older people. I'm not going to spend too long on this because I already talked about it a bunch, but I like this. You've probably seen this cartoon before about equality is everybody gets the same thing, which if you think of the father and the two kids is not so good for the youngest kid. But equity is everybody gets the same experience, the same quality of experience, and they get whatever they need to have the same healthcare or the same view of the ball game. We do not remotely have equity for older people in our healthcare system. We need to recognize the treatment harms of aging. Um, I'm just going to go through this quickly. Again, it could be a whole other talk, but not providing treatment for someone just based on age, not looking at how healthy they are, how functional they are, not asking them what they want or don't want, because our risk benefit ratios are really different. I've been taking care of older patients now for a long time, nearly 30 years. And what people choose is vastly different. So many treatments don't lose effectiveness with advanced age, although the risk benefits may change. But you can't just say, I'm not going to do this for you because you're old. Now, some countries do that more than ours. I'm in Britain now. They do that more routinely. What we do in the US is more the second thing, over treatment. So you're 85 and frail. What the hell? I'm going to give you this treatment that was proven so effective in healthy 50-year-olds. Oh my God, look, you're dying. Wow, you really are old. You know, it's crazy. You have to think about the risks and the benefits for you and your particular situation. Then mistreatment is when people think about disease. Oh, we're just going to tweak this for your blood pressure. I'm just going to check these tests, you know, to make sure you don't have pre-diabetes, which is not even, you know, depending on your age, maybe a nothing. When your primary need is that you're incontinent, and that's because your knee hurts so much you can't get to the bathroom, and they're talking about your blood pressure, or something else, or you can't get to food, or you're living in a place with a lot of stairs and that needs to change, but you can't find another place, or you're wondering which is the best place to go to. There's so many ways in which the focus can be on medicine, where what you need is care for your health. Or they're focusing on medicine. And let me give you another medicine for your osteoporosis. Instead of giving you a gym membership, which would enable you to do the one medicine that treats, you know, diabetes, high blood pressure, many cancers, Parkinson's, preventing Alzheimer's, preventing heart disease, helping with anxiety, depression, insomnia, etc., exercise. But no, we're not going to offer you that. And then there's the triple whammy. When people get harmful treatment, they don't get the needed treatment, and the essential care that they need to be happy and healthy is deprived. They are deprived of that because it's the social worker who would do it or something like that. So when we look at the human lifespan, you Google it, you often find an image like this. There are 4 images for childhood: the infant, the toddler, the kid, and the teen. 4 images, I would argue, for adults, because if you look at the second to last person, he's got bifocals. I've got progressive lenses here in my late 50s. She's got thicker hips. I sadly have slightly thicker hips because of COVID. So, you know, there are 4 areas of adulthood, from a young adult to a middle-aged person, or one could say older adult. But then there is this leap to a person in a wheelchair. As if there weren't decades of old age. I mean, if it legally begins at 65, they're literally just decades for most of us. And it flies in the face of what we saw with COVID, which actually you can fill in this for adverse events based on procedures, side effects, treatment likelihood of, you know, doing harms. The risk is lower for people in their 60s, higher for people in their 70s, higher still in 80s. Is this for everyone? You know, might you have a really sick person in their 60s do poorly and a really healthy person in their 80s do well? Absolutely. That's what I was just talking about with over and under treatment. And yet there are some averages. There are some things that we can expect. And that data has been known forever, and we don't include it. Just as we don't in the business world. People say, oh, you know, we're going to get rid of the older workers because they're slower. Well, all they're thinking about is speed. They don't think of all the things that have been proven in, you know, little publications like the Harvard Business Review about the advantages to age diversity on teams, or the things that older workers tend to do better. So we selectively use the evidence across sectors. You know, think about all the businesses, all the restaurants that are so noisy, and who has the time to go out to eat? It's insane. So I propose, and this is part of the image of elderhood, where we have childhood, we have adulthood, and we have elderhood, which starts in this blank area, or sometime between man in bifocals, woman with hips in the blank area, depending on who you are, and extends to maybe you're in a wheelchair before the end. But, you know, are you 72 when that happens? Are you 95? Are you 106? I don't know. There's a lot of stuff going on in there. We need language for that. That would be a great thing for Ashby Village and anyone else to do, to come up with language. They're not, you know, nobody's going to agree on everything, but language so we can actually name the substages of elderhood. And then creation of age-friendly environments. I'm going to go quickly through this because, again, it's a whole other talk, but really thinking about how to make age-friendly communities. And again, that's a great, the villages do things like this, but thinking about all parts of, getting your house ready before something happens. Thinking about other ways of transportation when you're going to retire from driving, because if you're going to live long enough, you're going to have to retire from driving. Thinking about whether the outdoor spaces invite you, not just kids and adults, and on and on and on. So many good things. There are starting to be really cool parks with areas for older people to work on balance, as you see this woman up above, stretching and strength with the men below. There are more pickleball courts. But here you see some people in Chicago doing Tai Chi, which is the #1 exercise to prevent falls, but they're not getting that soft environment that could cushion them if they did fall the way the kids do. So still a little discriminatory, but awesome that people are just grabbing the sidewalk and going with it. Thinking about ageist language. Now this pertains more to younger people often, but think about people who are older than you or people who are in nursing homes. Do you talk about them as they or them, as people who are more frail or more disabled versus we and us? I have tried to do that. I do sometimes slip, but really think about we and us as human beings, hoping to live a full lifespan. Obviously this is teaching people not to use elder speak. In other words, speaking to an older person, as if they're deaf when they may not be, but also as if they were a baby or a pet. Saying things like, oh, the person's young at heart, or you don't look your age. Actually, you are the age, you look that age because that's the age you are. That's one of the ways that age looks. And young at heart means that an old heart is a bad heart. So if they're saying that as a compliment, meaning you're good, like you look young or you're young at heart, that means young is good and old is bad. I mean, do you really want to be 16 again? I certainly don't. Yeah, so you can see more of this, but really calling people on it in a nice way. Say, look, I know you're trying to be nice. And I just need to point out to you that this is actually, there's a term for this, it's called elder speak. And it's considered kind of insulting and derogatory. And I know you wouldn't do that if you knew that. So I just thought I should tell you. And then finally, a change in the way we think about aging and older people is what's required. We need to tell some of the true stories about why older people on average were happier than younger people in the pandemic. We all know kids who have suffered, young adults who have really suffered, middle-aged people who had their kids at home and were going nuts, like certainly all my colleagues, like in their 30s and early 40s, brutal, absolutely brutal. So these are some unhappy people. And that's actually building on, and we found that yes, people who were locked into facilities didn't do very well. People who were already isolated or had pre-existing mental illness didn't do very well. For every rule, there's an exception. But by and large, older people, perhaps for the same reasons they lived to be older people, showed more resilience and had more happiness, just as they do in regular life. So these are studies. Bellflower just did a review last year of all the studies about the U-shaped curve of happiness, which some people dispute. Again, it's not everybody, it's in a majority of countries, but happiness tends to go up, anxiety goes down, and life satisfaction goes up as we move into our 60s. And it is thought that this is in large part to the fact, not as a negative side effect, but as a positive of things, our options getting smaller and our ability to make better choices. Having fewer options, realizing the clock is ticking and making better choices, the choices that matter most, not the ones that are going to further your career necessarily, or, something else. It's really the things that matter, that have meaning and purpose. We also know that internalized ageism kills. So another reason I've been talking a lot about, do unto others as you hope will be done unto you going forward. This is just one graph showing that people who have negative thoughts about aging and old age tend to have their first stroke or heart attack 7.5 years earlier than people who are more positive. There are probably two reasons for this. One is if you're feeling negatively about yourself, you're putting out all these stress hormones, that kills. And the other is you're less likely to take care of yourself if you don't believe it can make a difference. And Becca Levy, who's at Yale, has shown this across all sectors of health and well-being. So this was San Francisco's anti-ageism campaign. I kind of love it. So you see the people today on their eyes. That's where you see the wrinkles. And you see their younger selves above and below. And it's just to remind us that in every adult is an elder in training, and in every elder is an adult who matters. And sometimes saying that or showing that to people is helpful. And then I like to finish with 2 quotes from Ursula Le Guin, who said, "To tell me my old age doesn't exist is to tell me I don't exist." And I think, yes, the Grey Panthers have been around for years, but the anti-ageism movement hasn't taken off the way Black is beautiful, I'm here, I'm queer, and feminism have taken off. And because people deny it, whereas people tend to not deny their gender identity or their race. But people deny their age. And if everybody who was old said, I'm old, this is one of the ways old age looks, we would have a much less ageist society, because age does matter. And as she says, kind of amusingly, if I'm 90 and believe I'm 45, I'm headed for a very bad time trying to get out of the bathtub. So my final thought is, what if the greatest limitations of aging come from our imaginations and policies and not our physiology? Thank you for your attention. I think I went a little long. I sometimes get enthusiastic, but I will stop now. I'd be happy to take any questions.
Okay, thank you so much, Dr. Aronson. That was a very interesting and wonderful talk, actually very important talk. So thank you very much. And yes, we have quite a few questions here. And I want to start with one question that I think is fitting as a first question. So what can we do to make our voices heard loud and clear in all instances?
Oh, all instances, lots of things. I think when, it sort of depends if you're in one of those situations where people are just like not seeing that you exist. You can just say, oh, excuse me, I was there in line, and just move your body forward, take up the space, own the space, don't just let it happen. I think really saying like, we're a group of old people and we saw this and this isn't right and you need to address it, or using terms like structural ageism, because people are getting used to structural sexism and structural racism. Now, could you get pushback on that, saying, oh, we're thinking more about racism now? It's why I like to point to the intersectionality data, because if you fix one ism and don't address the others, you're in real trouble. But I think it's really just constantly and consistently standing up for older people, but at the same time, not having it be the only tune. And actually, in something Roberta said to me, she said, we work on lots of issues like climate change, right? Because all the people under a certain age think, none of us, and I'm included in that group, ever think about the climate. And so really being present on all the issues that matter to people, like race and climate and everything else, so that it's seen that you're part of society, and standing up and speaking and owning that, no, you just said old people don't care. We're a bunch of old people. We're here. We care. Here's what we've done. And just make it visible and loud.
Yeah. How can we make the specialty in geriatrics more appealing to medical students? I think that's a good question. I have a son in medical school right now, and so is it actually part of internal medicine, or is it like a separate field right now?
Right. So it's actually a subspecialty. So you have to do internal medicine or family medicine first, and then you do geriatrics, which is kind of ironic because you do it the way you would do cardiology or GI, like parts, organ systems, but it's a whole stage of life. And that's in contradistinction to pediatrics, where right out of medical school, you specialize. And I could see arguing it either way, and I wouldn't necessarily say, oh, we need to divide the human race by age, except for we already have for kids. And the reason they started having pediatrics is actually kind of interesting. It was the beginning of the last century. And it was kids were dying in huge numbers, kind of like older people are now. And at some point we have to die. So maybe that's not entirely fixable, but but kids were dying in huge numbers, and World War I was coming, and they were like, well, if all the boys die, we're in trouble. So for all the wrong reasons, pediatrics was started. So it doesn't really matter why they do it, but we need to make it bigger. I think it's disdained partly because they don't get much of it. I mean, literally hours to days, most people can't remember, or they think it was a week. Everything else gets more attention. If we had proportional, you know, if I could wave a wand and have everything be proportional, that was great. That would be great. I also think if we looked at everything like, here's the heart, here's what it does when you're a kid, when you're an adult, when you're an elder. Oh, here's the foot. Here's what you think about in a kid, you know, stuff like that. So it's hard without combating ageism. I also think geriatrics is part of the problem. A lot of geriatricians. So what geriatrics has always said is there's so few of us, so we're going to take care of the oldest and the frailest. Well, those are the people against most people, you know, against whom most people have the most prejudice. So if you'll say to someone, "Oh, I think you should go to the geriatrics clinic," they're like, "Oh no, not me. I'm fine. You know, I'm okay." You know, instead of it's like, "Oh my God, I actually got a geriatrician," which is really what it should be like in this country, because it's somebody like now I've started to see people at 60, and I think about how are we going to keep you as healthy as you can going forward. But instead, my profession provides really good care once you're quite old and frail, and that's fantastic. I'm not saying I don't love doing that also, but most people would rather delay that if possible. So if we expanded geriatrics to be what it should be, the specialty that focuses on elderhood, that would help a lot. I also think there is amazing science in geroscience, which is going to transform how everybody practices medicine. So the people who like sciencey stuff should know about that. And the tech, the ability of tech to be helpful is also huge. So the techie people should like, you know, but we don't talk about any of that well enough. I'm gonna do that shortly. The pandemic kind of threw me anyway. But I think those would be some ways, you know, and yeah, it's so much fun. I don't know, we're just happier than everybody, but anyway, I don't know what's wrong with people, honestly.
So, what departments of our federal government are in charge of clinical trials, and how can we get more trials that include older Americans?
Well, so the NIH is the one that makes the mandates. So you would go to the National Institutes of Health, and it has all kinds of sub-institutes, and they do have these new 2019 inclusion criteria. But I think you have to work I sort of alluded to this, but I might not have been clear enough. That they can't have age limits. They need to work harder, and this is actually true for people of color also on outreach. How do you bring people into trials, and how do you bring people who have some disability, whether it's cognitive or physical, into trials? So if the trial is across town and you have to take a bunch of buses and you don't walk very well, or you have to drive like to UCSF where there's no parking or it costs a fortune and it's a nightmare, you won't do it. And if your brain doesn't work well enough, how do you consent people who are the caregivers, you know, for people to getting people into trials? So a couple of things. One is you need to work on their outreach methods and push them to develop better outreach methods, and to put into grants that a certain percentage has to go to that. Because otherwise they'll spend it on the science and they'll say we didn't have the resources for recruitment to get the people of color or the old people. It's usually those two categories. And then the other thing is to get rid of these things that say when you have what they call comorbidities, when you have certain diseases, you can't be in the trial, because they'll say, well, you can't have Parkinson's. Well, it's the rare Michael J. Fox who gets Parkinson's in their 30s, right? Most people get it in their 60s, 70s, 80s. So when you say we're not including people with Parkinson's, you're basically getting rid of the old people. Especially if it's like a Parkinson, you know, I don't know if it's something related to that. So those would be some ways you can really make noise. And then, you know, these days the federal government funds a smaller percentage. So make noise to companies also, you know, like Pfizer and Moderna didn't include so many old people in their COVID trials. So really vaccines were given to people who didn't realize they were maybe not safe or efficacious. Luckily they were, but that was dumb luck.
Okay, the next two questions are actually more like medical questions. If one is 85, should one get 2 flu shots? And then the other one is, what is your opinion about older adults getting a second COVID booster?
So 2 flu shots, if you get the higher dose flu shot, you don't need to get 2 flu shots. So what you should do is get the higher dose one. And this was actually interesting. San Francisco Department of Health was trying to get flu shots to people in facilities, and they were just doing the regular one. And I was like, you wouldn't give like a 3-year-old the 6-year-old dose or vice versa, you know, and you have to use these kid analogies, which I apologize for, but it's like the only language they speak. So, you know, best to always get the higher dose flu shot. It can be hard to find. That's also wrong. So that's another lobbying campaign. If this is the one that protects older adults better and there's good data for it, why is it that so many of my patients go to pharmacies and say, oh, they didn't have it, I should just get the regular one? Now, getting any flu shot is better than getting no flu shot. But we know how many old people there are in the country. Let's make enough doses of the higher dose one. If you got the lower dose one, you could try getting the second one. It probably wouldn't do any harm. You still wouldn't have as much as the higher dose. I think I did actually once have a patient do that. It's not really, I'm not sure I should be saying this in public. I'm not sure, it's like not standard of care, shall we say. So I don't want to get in big trouble. And then the second question was what? Do you remember?
About a second COVID booster.
Oh, a second COVID booster. It's looking like possibly. I mean, I think especially if you have not had Omicron and it looks like BA2 is coming, that might be a good idea. If you had the first booster and you had Omicron already, I mean, the BA2 is a variant of Omicron. So if you had that, you're probably okay. It's a little iffy, but I think probably the concern is that it wanes, and then what happens if there's another surge? So, you know, it also depends on how careful you're being and how careful the people around you are being, because we certainly see these days that some people are still being careful and some people not so much.
So I think that's an interesting question too. Can you identify countries that do a particularly good job with aging? And then there's a follow-up question to that. So,
oof, not really. Not as much as I'd like to. You know, people are always like, well, what about Asia? Well, it turns out in the latest survey, which was I think 2018 or 2019, rates of ageism in Asia have gone way up. I don't think anyone does a great job. Japan may be better than many. South Korea, I understand, has some benefits, but you know, part of it is historical, that there just weren't so many older people until recently, and there's always a lag. I also think part of it is a problem that's hard to solve. So if medicine, when we got women's health, was after the women's movement, when they started admitting a lot of women to medical schools. When we got, you know, white coats for Black lives, was after civil rights movements, that where we started admitting people of color to medical schools. I do not recommend, it was brutal in my 20s, I do not recommend people in their 70s, 80s, or 90s go to medical school. So who's going to represent? It's a definite problem. But what I'm hoping is we can get more of the people who are in those age groups and still working within healthcare to take this on, to recognize this isn't them, it's us. I mean, our CEO who just stepped down in his 70s, our chancellor in his 70s, I'm pretty sure, our dean in his 70s, you know, I mean, and they talk about them, the old people, like, hello. You know, I don't know what to do about that.
yeah, the other question about other countries was are nursing homes better in other countries? I don't know, you're in England right now. I mean, maybe you know a little bit about England. I can say a little bit about Germany, but
Yeah, well, Scandinavian countries apparently do better to some, you know, they've done better with outbreaks, and better care, and had better places for visitation. And so I think sometimes in Scandinavia, I don't know about Germany, if you know.
yeah, I mean, the one thing I can say, they're not necessarily better or they do better. I mean, one thing's for sure, I mean, they're cheaper. I mean,
Yeah.
that's I think a big problem
Yes.
here, that everything when it comes to that is so expensive. Yeah, so here is a question about healthcare coaches. Do elder
Mhm.
healthcare coaches exist?
They are starting to. I always thought that was a great idea. You know, they started with the cancer coaches, and I was like, oh my gosh, to navigate the health system, it's totally perfect. So, you know, become a healthcare coach. I mean, if some of you need something to do, it's a good thing to do. Like, you can do it however many hours you want a week. There's coaching training in a bunch of places. I mean, it's a great encore career. You know, I don't know, for people who are looking for something else, or if there's there should be more of them. Also start, the other thing I think works well kind of insidiously is to go to a place and say, oh, and I think this person I'm with could use an elder coach, or an elder care coach. They'll say, what? I'll say, well, don't you have elder care coaches here? Oh, I thought this was such a good hospital. What a shame. And just keep planting the seed, or start doing it, start a whole volunteer corps that does it and do a trial with somebody. I bet actually we could find somebody in my division to do that with you.
So for those of us who have primary care doctors and not geriatricians, how can we ensure we get adequate care, that bioethics principles are adhered to?
You can bring it up. You can say, I went to a talk, blame me if it makes it easier, where they talked about overtreatment and undertreatment. And I just wanted to, raise that with you and make sure, we weren't doing any of that, and I wanted to think about things, not just to treat my diseases, but to keep me healthy as I age. And if you can't do that, can you send me to somebody who can help with that? What we're trying to do at UCSF is embed because there's just not enough of us to provide primary care to everybody who wants it. So we're trying to embed us in different clinics. So it might be you can find someone you can see as in consultation a couple times a year, to add that geriatric expertise. If you can't find a geriatrician, that could be a model that would extend and then just knowing what you need and what's possible out there so you can advocate for yourself. Or you develop your cadre of elder coaches who help.
Okay, so this is more like a comment. I have 3 postgraduate degrees. I'm mentally slower, but I don't think I'm demented. Yet servers, doctors, and even my own son talk to me as if I were slightly stupid. What is one good rejoinder I can memorize and have ready for a reply? I'm tired of being diminished by others.
Oh, I love this. It happens all the time. You could, it depends on how passive aggressive you want to be, basically. You could say something like, are you okay? Because you're speaking really slowly. Are you feeling okay? That's definitely passive aggressive. You can say, I don't know if you've noticed, and I know you mean well, but you're actually kind of speaking to me as if I can't hear you or understand you. And you're going kind of slowly. Do you think you could just speak normally? Because I'm okay with that. Make sure, though, before you do this, that you have indeed had your hearing checked, because what I do find is people have some hearing loss and it's worse than what they think. And so then they're missing things or they're answering inappropriately because they haven't heard correctly. And then the person assumes that there's something wrong with your brain instead of your ears. So hearing aids for everyone. But you can try that. Just say politely, like, hey, I know you mean well. And I don't know, or maybe you're not aware of this, but you're actually talking pretty slowly. And it doesn't, you can always use the I words. I feel a little demeaned by that. Do you think you could just speak to me in a normal voice? I would really appreciate that.
Okay, so I'm an elder patient at Oakland Kaiser with a primary care physician. Should I advocate to be assigned to a geriatrician, and how do I do that?
Well, Kaiser apparently doesn't believe in age groups, so you get a generalist. They have some geriatricians who go into care homes, but not really others usually. But it depends on the Kaiser, actually. So I understand that some Kaisers do have geriatricians. There might be a wait list, but I think you would just request that. And in fact, I usually advocate for people to keep requesting it. Because then maybe Kaiser will get the sense that people really want this. And if a place like Kaiser were to decide, hey, we're going to produce more geriatricians and we're going to incentivize them with, say, med school repayment, geriatrics is one of the few specialties whereby in getting more training, you get paid less. There are a couple others. Shockingly, they're also full of females. But most of them where you get more training, you get paid more. So that's a disincentive. It's especially a disincentive for people who now seem to come out of medical school with $200,000 in debt right at the moment where they might want to start a family or buy a home. So there would be ways to incentivize. I should have said that under the sort of going back to the question about how do we get more geriatricians. People have done studies showing that isn't the primary factor that ageism is. And part of the ageism is also that they see senior doctors feeling uncomfortable with older patients or not liking them. Why do they feel uncomfortable and they don't like them? Because they feel incompetent. Why do they feel incompetent? Because they are incompetent. Why are they incompetent? Because they didn't receive any training, so they don't know what to do. We go in and see the same patient. We know what to do. We love what we do. It's not a problem.
Can you please comment on recent report that pulse oximeter measures discriminate against Black people and result in them having poor COVID outcomes?
Well, so the studies on the pulse oximeters were done late 80s, early 90s, and there was not much diversity in the samples. There is some thought, so I don't know if people who wear nail polish might have had, a doctor take off the nail polish to check your oxygen when they really needed to know. So there's some thought that the same way the pigments in the nail color can interfere with the reading, so might skin pigments, especially in much darker people. But there's also some thought that it might lead to different measurements of making the oxygen seem higher than it is because this is what happens when you don't study people. So they've argued it in both ways. So when the oxygen seems higher than it really is because of the way things are being measured and because of maybe the red cells in the body, of people with certain red cell, like there's certain differences in red cells that track race, aren't exclusively racial, then you think the person is doing better than they are because the norms are on white people.
How can we get science to find even better solutions to hearing loss? Is there any way to get restaurants, for example, to understand the problem of any noise discriminating against the many old hearing impaired people?
Yeah, and even middle-aged people. I mean, you notice first people are like, they can't read the menu, and now it's getting to be like, can you say that again? So, it's like half the lifespan. It's insane. I always think like, if everybody over 50 didn't go to noisy restaurants, I mean, some of them would do fine and they'd probably be happier. That's annoying. Or, but really the amount of dollars spent by people over 50 is pretty significant. And then, you could also start a campaign to say, like put ratings online, like join Yelp and Yelp them and say, great food, too noisy, won't go back. And just like have a whole bunch of you rate certain restaurants and give them a ding because that's what they respond to is online ratings. You can also go more politely and say, hey, I don't know if you're aware, but this is really interfering with our experience. At least, is there a way you could have a divider where half was more quiet, like they used to do with smoking? Not that that worked either. This probably wouldn't work. I don't know. We need to get creative about it, but you find even younger people yelling at each other. So it might be something that's good for everyone.
Right. I think so.
Yes. And aren't they more likely to be deaf later if they're constantly in restaurants screaming at each other for decades? That just doesn't seem good.
That'd be good, yeah. So Ashby Village has MedPals. Is there a specific coaching training where we can look into for our MedPal volunteers?
I know there are health coaching programs. I can't remember if Merit has one. I know the University of Arizona has a health coaching program, but they're like health coaching trainings. The other thing would be, since you're at Ashby Village, couldn't you get someone to do one like through UC Berkeley Extension? That would be perfect. Like one of those certificate programs or something. I don't know. I actually don't know how much of a course you need. Like, is it one course? Is it you take a few courses and you get certified? I think there are certifications for health coaches, but it would be a place to start and work with UC Berkeley on that. And Carrie Sweeney through the alum network there.
I'm a 65-year-old Black trans lesbian, disabled, Medicare, Medi-Cal. My provider is Kaiser Permanente. How do I find healthcare without every visit to a medical professional being a minefield of overt and passive-aggressive discrimination? For example, going in for a test and the nurse gives you a nasty smile before loudly as possible asking how a woman can have a prostate gland.
Oh God. Well, first, I'm incredibly sorry that that is still happening. I mean, because if you figure if it's happening here, God only knows what it's like elsewhere. You know, it's hard to think of an answer that doesn't put more work on you, as in filing a formal complaint, because that is completely inappropriate, unethical, and unprofessional behavior on the part of the tech. You know, but then, you know, you run the risk if every time you have to file a complaint. Almost all health centers at this point have diversity people, and they all have ombuds people. And I wonder if you just got in touch with them and said, here is my experience. It's routine. You clearly have problems. Can you find, you know, and maybe a health coach would be helpful for this too, you know, to navigate the system. But also, you know, that's intersectionality. I mean, that's more than what I even mentioned earlier. So I think trying with the diversity, equity, and inclusion group and with the ombudsperson, because clearly that is unfair and, you know, borderline illegal treatment. And unfortunately, the burden falls on you, which is not where it belongs.
As elders age, it is critical that they maintain use of their devices and some level of proficiency, which allows them to stay connected with the other generations and access to self-help. How can we influence the tech companies to stop updating to the point of making elders unable to recognize how to use apps they depended upon? It leaves them isolated and no longer able to participate in so many of their interests online. The insult is they call their simple devices the dummy model.
Right. Yeah. Well, you know, Mark Zuckerberg famously said that nobody over 30 does anything of any importance. So I'm kind of loving that he's over 30. We'll see how that goes for him. Again, the tech companies now are all trying, you know, the as they like to say, the elder space is hot. So they all have wings that deal with elder related stuff. So you could get in touch with them. I think that's actually a great article I could potentially write if whoever that is wants to get in touch with me, because I think we could talk about the many ways. It's again that equality versus equity. They're thinking, well, we're making this equally available to everybody and not realizing that it's an inequity that they are perpetuating structurally. So sometimes it's just that level of awareness. The other thing I like to talk about with tech is that it's not old age per se. It's being a digital native or not a digital native. There was an article in the New York Times like 10 years ago talking about how 5-year-olds were better than 11-year-olds with, I can't remember what app it was. You know, so if the 5-year-olds are beating the 11-year-olds, the rest of us are just doomed. But I really think outlining the issues and then talking about how tech needs to have a bigger, you know, they need to try it on all different sorts of people. And you could also have allies, you know, allyship on younger people, really thinking about, is this helpful? Is it not? Because it is infuriating. And sometimes it's infuriating to the younger people. We had a 21-year-old nephew with us recently, and on the iPhone, where the menu was on the browser went from the top to the bottom, and it was making me insane. And I thought, my God, I just can't cope. And then he updated his, and he was like, "This is the dumbest thing ever." And then he figured out how to fix it, and so then I did mine too. Anyway, so we also have to assume, we shouldn't assume that we can't do it, is one thing. Maybe get some help in using the new one is another thing, but also making the companies aware that sometimes they're doing a huge disservice. And, you know, they're really concerned about the youngest people, getting them addicted. So they're not going to be so concerned, but for PR reasons, they have to be somewhat concerned.
There are really quite a few questions, pretty much asking how to ask your doctor or how to respond to your doctor. I mean, when, for example, a doctor tells you, Well, that's what happens when you get older. So how can I discern what's accurate in this statement and what's ageist assumptions?
Um, yes, so there are a couple answers to that. So one, aging isn't a disease per se. It does increase your risk of disease, and there are some changes in the body, often decline, wear, and tear. There's a joke I tell in the book, which remains my favorite joke, which is about an older man. He's in his 90s, I think, and this was a true story in New York. He goes into the doctor because he's got this pain in his left knee. Doctor examines it, talks to him, whatever, and he says, well, what do you expect? The knee is 94 years old. And the guy says without missing a beat, well, my other knee is 94 years old too, and it doesn't hurt a bit. So, if you happen to have two of something and one of them is a problem, you can always use that. Well, clearly it's a disease because the other one is fine. And you can also say, I understand that my risk for having problems goes up as I'm old, with age. But that doesn't mean it isn't a problem, a disease, or a condition with treatments or ways of managing it. I would like to discuss the ways of managing it. And if you don't know them, could you refer me to someone who does?
There is actually some information. There is a gender pathways clinic at Kaiser in San Francisco. I think that's in response to one of the questions we had before. They claim to provide culturally competent care. There is also something in the East Bay, but they didn't know, or the person who recommended that didn't know the name, obviously. So yeah, just as for your information.
That's great.
Yeah.
Thank you. Pathways.
And how can I discuss my preference for holistic or herbal medicine rather than prescribed meds with lots of side effects? I'm proactive in trying to find less harmful alternative solutions for various health issues related to the process of aging.
Yeah, I think it's good when if you have a chance to interview doctors to say, I'm interested in, the well, and you can actually use the word geroscience. So what some people call anti-aging. I don't like anti-aging because anti-ageism makes sense to me. Usually you're against the ism, but only in old age are we against the thing that happens to everyone universally. So it's sometimes called anti-aging medicine or longevity medicine, although it's as much about quality of life and healthy lifespan as it is about long life, or geroscience. And just say, you're interested in alternative and geroscience approaches to increasing your health span. So if you use some of the lingo, that will be helpful. And you also want to minimize harms, and you know that older people have more side effects from conventional drugs. That you would, is that something they're comfortable with? And again, if they're not comfortable with it, are they comfortable with partnering with someone who does know about that? Because maybe then you also go to an integrative medicine doc or something. I now have a clinic out of our Osher Center, which does integrative medicine. It's been I think I'm more conservative in some ways than some of my colleagues, but at the same time, because of where geroscience is going, and because we do see all kinds of associations with certain vitamins and minerals and all kinds, they let me do preventive aging at that clinic. And I think we're going to get more and more people interested in it. But it is too often concierge. So make sure they're at least okay with it, so that when you tell them the list, they're inputting it in your medical record, because there are some drug interactions, and ideally they'd know something about it. Or you can always very generously say, would you be willing to learn about this with me?
So I guess before I ask another question, I want to say, you have been really generous with your time, so I just want to ask you, are you willing to answer a couple more questions? Or
Sure. Yeah. No, thank you for asking. I'm okay.
Okay. Could you say a few words to the new AB 2546 Resident Designated Support Persons Act and the Coalition for Universal Long-Term Supports under the new Master Plan on Aging?
Yeah, so a bunch of great caregivers coalitions have been working hard on this bill because people weren't allowed in. And a nursing home, it's their home, and you're not letting family in. The other insane thing that happened in assisted living, board and care, and nursing homes, in all long-term care facilities, is that paid aides who, had less at stake and were from communities often more likely to be infected with COVID were allowed to come in and provide personal care to people. But family members, like I would never, I have an 88-year-old mother, like I would never take any risk or go anywhere without a mask because I want to be able to see my mother, but sometimes I couldn't see my mother. But surely the families would be less likely to infect the residents. And so families weren't allowed in. And that's a problem because it also doesn't acknowledge that for a lot of people, the family is a prime caregiver. So it just showed the complete ignorance. I can tell you at both city and state levels in California, so city of San Francisco, but I hear it was as bad in the surrounding counties. The people in charge of making decisions did not know who oversaw nursing homes versus assisted living and did not understand that there weren't necessarily nurses at assisted living, did not understand how they operated, what the rules were. They really didn't understand. And so these coalitions have been working to talk about essential caregivers, as in family. We somehow prioritized paid strangers over essential caregiver, family members. And I like to think of that in a bunch of ways where you're an essential caregiver if you're providing some care. But I also like the term essential visitor because we literally had people die of loneliness and social isolation. So maybe the person didn't need care, but they got so depressed and hopeless that they just died. Because what's the point in living? This is going to go on for years, they say. I'm already so old. I'm never going to see my family again. And we just know people died. So we just can't have a situation where the government can keep out, people who are essential to the well-being of the people there and claim that it's being done for the well-being of the people living in those places. So really support these bills. If you want to get politically active around this, I think these are really good ways of doing it.
I'm often told a certain test will be discontinued. I assume this is because of my age. How do I find out what is right or if this is right?
It's such a good question. Well, it turns out my boss was the one who really, not Bob Wachter, but Louise Walter. There are actually two Louises in our division of geriatrics. So unlikely. It's like being struck twice by lightning, but it happened. So she was the one who figured out that, or started this thinking. So it's not just your age. So society guidelines will often have an age cutoff. And you saw that graph where I showed, risk was lowest for people in their 60s and higher in their 70s and highest in 80 and up, 85 and up. So the benefits do go down as you get older and the risks do go up for procedures from, mammography to, prostate testing with PSA to, colonoscopy to everything. But it depends on a bunch of things. So it depends on who you are. Are you a person who never liked tests? Well, then you shouldn't be getting a test. Are you a person who, felt really sick the last time? It's just not worth it to you again, so you're happy to stop. But more importantly, it's what's your functional status. Because we know that if you can go out and walk a few miles, you're pretty healthy. If you can, walk or jog up a couple of flights of stairs, if you're functioning well, if you don't have a whole host of health problems or at least serious ones. Because what determines whether a test is worth it or not and whether treatment is worth it is how long you're likely to live. So it's called lag time to benefit. And another colleague of mine, Say Lee, has done a lot with this. So that's the time between when you take the risks of the procedure until you're going to accrue the benefit. So for instance, a woman with osteoporosis taking osteoporosis medications, she will begin to get benefits. So her fracture risk will start to go down at 12 months. But if you get a colonoscopy, which everyone who's had one knows the prep is probably the worst part and very arduous as you get older, the lag time to benefit is 10 years. So if you don't think you're going to be around in 10 years, it's probably not worth doing. But you could have a healthy, 78-year-old who's almost certainly going to live into her 90s. And you could have a 64-year-old that's very sick and is not going to see their 70s. So it should be based on this algorithm that Louise Walter came up with, which is your preferences, your functional status, your health status, and take it from there. So you should ask them if they know the lag time to benefit for that test. And if not, would they please look it up for you? And there is something they can use to calculate your likely life expectancy. It's not a crystal ball, but there's something called e-prognosis, also developed by colleagues of mine. So sorry to be talking about it, but our division has done some cool things. So just bragging about my colleagues, where you can put a bunch of information in and get a sense of a time span that's likely. Now, the bigger it gets, the less likely. But we do know, even from life charts going back years and years, that people in the lowest health status have very, the life expectancy excursion can be up to 12 years between people of the same age, say 75 with poor health status and 75 with great health status. One can have like a 4-year life expectancy and the other one has a 14, 15, 16-year life expectancy.
So maybe one more question here is, I'm sorry, I'm not familiar with that term, geropsychologists.
Geropsychologists, maybe.
Psychologists, yeah. I mean, it was, yeah, I suppose so. Okay, I thought it's a special word. So geropsychologists are trained to counsel elderly who suffer from loneliness, etc. What can be done to increase the number of geropsychologists?
Yeah, it's the same thing with everything, Gero. I mean, I have a social worker friend who tried to start, social work, and most social workers will deal with older patients. It's something like 70% of them deal with them and tried to start it at Berkeley, and they weren't interested. So please do something about that. I think there has to be more representation in the training places, more people showing how fun it is, showing all the options, one of the things I like is that there's so much you can do and nobody else knows how to do it. You can be creative and it's always interesting. You don't do the same thing over and over and over again. Like if you were just fixing cataracts all day, like, no, I couldn't do that. And some people do it and thank God they do, so we can all see, right? But just, think about the ways to stimulate and interest people, model, and don't just talk about show them across the spectrum of old age, because some people are going to want to deal with frail people, and some people are going to want to deal with healthy aging people, and some people are going to want to deal with lonely people, some people are going to want to deal with anxious people. So really get more training into the training courses, and also more ways to inspire and show the wealth of opportunities for people.
Well, there's just one more question that came in, and I think is a really interesting and important question. Do you believe that it can be a rational decision to want to die because of one's limitations with aging? I'm concerned about living beyond when I want to, probably in a badly run nursing home. Shouldn't geriatrics include consideration of giving older people the right to choose death?
Yes, I completely agree. I know not everybody does, but I guess I've seen enough people where really nothing worked. They're in the bed and the brain doesn't work very well and the hands don't work very well, and they're soiling themselves regularly and they can't see very well and they can't hear very well and they're not comfortable and they don't have any meaningful activities. And it's not mine to decide for that person. Let me make that absolutely clear. But we have medical aid in dying now. But it's very adultist, right? It assumes that, so we have, people talk about Oregon, but we actually have it in California, and it is done at many or most medical centers, including my own. But you have to decide to do it while you can still do it yourself. And you also have to be able to take the pills. So sometimes when people get to that place and it's about all the accumulated wear and tear of old age, maybe you can't open the pill bottles. Maybe you can't hold the glass and deal with the pill at once. Maybe, it's assuming you're a youngish person with cancer and you have a certain amount of time and pain left, and so you can kill yourself. There was a proposal in New York State about for people with dementia, when they got to a certain phase, they were either allowed to stop eating or have food withheld if they could no longer make that decision, as long as comfort was provided to their mouth and lips. So there are bills like this, but it's politically fraught territory, because you can imagine people killing off their older relatives, or, you know, to get their money, for example, or to get the house or something. And we see this already in some directions and other places where people are kept alive. So you get the house, or you get to keep living in the apartment. So it is absolutely a slippery slope, but it is, again, one of these areas where there isn't equity, because it's a very adultist right as it stands now. I think we need to acknowledge that a person who, is depressed and wants to die at 27, 47, 67 is very different from a person who's 94 and not one of the key parts is working. In the former case, maybe we treat the depression, maybe we get some compensation things and the person's life feels worth living. We know that can be done. In the case of the 94-year-old, who is incontinence and can't walk and can barely eat and can't hear and see, we cannot help. And medicine has done this thing where we keep making people live longer, but it's not willing to spend equal amount of attention on the consequences of that. I actually have a colleague at our dementia center who told me the other day that she has been ranting internally about cardiologists because they keep saving people, and then she sees them at the dementia center and they're not happy about that at all. So I think we need to start discussing these issues and talking about them and letting people express their opinions and giving them back that autonomy and agency that everybody deserves at all ages.
Thank you so very much, Dr. Aronson. That was great. I mean, so many questions. Great, really great. So, and I want to end with a comment from one of the participants. I bet we are all wishing now to have a doctor like Dr. Aronson. And I want
thank you.
So,
I have some pretty terrific colleagues too.
Again, and now on to Rochelle.
Thank you, Sigrid, and hello, everyone. I am Rochelle Lefkowitz. I'm a board member of Ashby Village, and I'm the chair and co-founder with the late Marcia Friedman of the Ashby Village Arts and Culture Series. And so on behalf of all of us, thank you so much, Louise Aronson, for this extraordinary and rich arts and culture event. You have left us, well, over 300 of us, with so much to think about. And as has already been said, wishing we could be your patients. For those of you leaving here today who are hungry for more of Louise Aronson's wisdom, who have not yet read Elderhood, her best-selling book, it's now out in paperback and is available at your favorite independent bookstore or your local public library. Thanks to our co-sponsors today, Ashby Village's Health and Wellness Series, with our special thanks to Roberta Pressman for all that she did to arrange for today's outstanding presentation. And thanks to the Ashby Village Arts and Culture Group, our exceptional question and answer manager, Sigrid Duisberg, Irene Marcos, Rondi Saslow, and Betty Webster. Thanks for all you and our AV Communications Committee and our wonderful interim executive director, Avi Rose, did to spread the word about today's event. Do look for and share the story about today's event in the upcoming April issue of Village Voices, Ashby Village's monthly newsletter. And look in the May issues for news of upcoming arts and culture presentations. If you wish that more of your friends and family and neighbors and former coworkers could have heard Louise Aronson today, I have some good news for you. The recording of today's phenomenal arts and culture event will be up on the Ashby Village YouTube channel by tomorrow afternoon, thanks to our delightful new Ashby Village staff member, Jessica Sterling. And in order to find that, all you need to do is go on the Ashby Village website, look at the upper right corner button, and that will get you to the YouTube. And the website again is ashbyvillage.org. So thanks everyone for joining us this afternoon. And now back to our delightful new Ashby Village staff member and terrific tech support, Jessica Sterling.
Thank you. Thank you all for being here. And thank you so much, Dr. Aronson, for all of your wise words and answering all of our questions. Thank you so much. Goodbye.